Thank you to HIV-NAT for inviting me to give this talk focused on STIs in the context of PrEP and HIV management services. I would like to acknowledge the traditional Indigenous owners of the Australian land I'm giving this talk from, which is the Gadigal people of the Eora Nation, and pay my respects to elders past and present and all Indigenous people listening to this talk today. My disclosures are listed here. I have received research funding from 2 diagnostic companies, and this funding was part of an Australian scheme called the Industry Transformative Research Hub. It's a scheme which encourages private companies to provide resources which the government matches and to facilitate private-public partnerships, particularly for this instance in the area of antimicrobial resistance, and there are more than 20 investigators involved in this large collaborative grant. So let's start with PrEP uptake in the Asia Pacific. In regards to progress so far, the global goal was to get 3 million people on PrEP by 2020. However, the target missed by a large margin due to issues related to lack of policy guidelines, cost, acceptability, availability, and also implementation issues. There are new global targets which include getting 4 million people onto PrEP in the Asia Pacific by 2025. Asia Pacific is only at about 1 to 2% of the target and accounts for less than 10% of global users. Barriers to implementation include lack of policy support, including appropriate guidelines. Many Asian countries now have PrEP guidelines as seen in the red and increasing by year. But about a third, as you can see in the grey, by 2021 still don't have PrEP guidelines. Also, as shown in Thailand, the methods of delivery are important, with key population-led services playing a pivotal role in expanding access to PrEP. Only a small number of countries such as Australia, New Zealand and Thailand have national PrEP programs, which are the countries on the left in green, with many others still undertaking trials as a means to provide access, seen in purple, or rolling out post-trial, which you can see in the blue, but overall access is still limited, as you can see on the right. However, these trials do provide great opportunities to fine-tune protocols such as STI testing that will be included in broader national programs. The WHO recommends integration of HIV, syphilis, chlamydia, gonorrhea, Hep B surface antigen and hepatitis C for MSM into PrEP programs. Among the PrEP programs that have included STI testing, data are accumulating to provide an epidemiological picture of STIs among PrEP users to inform policy and practice. This systematic review by Jason Ong shows that for chlamydia, for gonorrhea and syphilis, about 10% or 1 in 10 tested positive for chlamydia, 10% or about 1 in 10 tested positive for gonorrhea, and about 5% for syphilis, as you can see on the right-hand side under the prevalence column. Overall, a quarter, about 24%, of PrEP users at baseline tested positive for at least one of the 3 STIs. These positivity data demonstrate that PrEP is being well targeted to those at higher risk. Similarly, in Thailand, high positivity in people starting PrEP at 34%, as well as people living with HIV at 51%. It's important to remember that PrEP will protect a person from acquiring HIV, and U equals U, or treatment as prevention, will protect a person from passing on HIV. But if a person's not using condoms, they'll still be at risk of acquiring and passing on STIs. So they need also to have access to quality STI testing and treatment services while on PrEP. STI testing is therefore recommended 3 monthly among PrEP users, a guideline which aims to capture STIs more quickly and get them treated. But not everyone on PrEP will get an STI over a 12-month period. Data from Australia show that half of PrEP users, you can see on the right in grey, did not have an STI over a 14-month period, but a small proportion, seen in the dark blue at the top, were diagnosed with new STIs regularly. So these data could provide an opportunity to focus STI prevention services, particularly among PrEP users with repeat STIs. And these PrEP users may be good candidates for prevention trials, such as for vaccines. The study also showed that 27% of all diagnoses were concurrent for chlamydia and gonorrhea, indicating the importance of testing for both chlamydia and gonorrhea together. These are data from the EPIC New South Wales PrEP program in Sydney, Australia, which is globally one of the largest PrEP demonstration projects, which showed an unprecedented reduction in HIV in the first 12 months of rollout at the population level among men who have sex with men. The study also carefully collated data on STI testing and the results of the STI testing, not only when the men were on PrEP, but also before they commenced in the PrEP demonstration project for a 12-month period beforehand through an innovative data collection system called Access. The graph on the left shows the findings for chlamydia and the graph on the right shows the findings for gonorrhea. And the data is divided into two categories. The first is before commencing PrEP and to the right after commencing PrEP. Before commencing PrEP, you can see for both chlamydia and gonorrhea that STI positivity increased. And at baseline, the first time point when participants started PrEP, positivity for chlamydia was just over 10% and the same for gonorrhea, which is similar to the systematic review data that I presented earlier. But after commencing PrEP, between 3 and 12 months, STI positivity for both chlamydia and gonorrhea remained stable and remained stable at all anatomical sites. So this information can be useful if there are any stakeholder concerns raised about PrEP leading to more STIs. In Australia, some stakeholders and media reports raised such concerns about PrEP leading to increased STIs because less condoms were being used. And that makes sense because as people start using PrEP, they gain confidence about it and they'll start to use condoms less, which has been demonstrated in behavioural data. Not all people who use PrEP will use condoms less, but in the behavioural data shows that some do. But these data in Australia were used by peak community organisations and provided to government to refute these concerns and demonstrate that despite some changes in condom use, having regular STI testing seems to keep STI positivity rates stable in this population, and similar findings have been observed in some other settings. Further to this, a very recent study by Dr. Michael Traeger carefully examined long-term trends in STI incidence, not positivity but incidence, similar among PrEP users in Australia. So this time it was at a national level. The data were derived from a national network of sexual health clinics, contributing again to a project called Access. In this analysis, there were 23,000 PrEP users, and it was restricted to PrEP users who'd had at least 2 tests, which was the majority of them. Over 3 years, there was no increasing trend, as you can see in the black line, in chlamydia incidence in PrEP users. And these were data derived from over 100,000 testing episodes. As you can see in the purple, rectal incidence was highest, then urethral, then pharyngeal. And there was no increasing trend in gonorrhea incidence between 2016 and 2019, as you can see in the black line. And rectal and pharyngeal incidence was highest and urethral was lowest. So why should STI testing be integrated into PrEP programs and other HIV management services? Well, there are a long list of reasons. STI testing enables early and effective STI treatment, which can prevent ongoing transmission, sequelae of untreated infection, including disseminated gonococcal infection, poor reproductive outcomes such as pelvic inflammatory disease, ectopic pregnancy, and importantly, infertility, poor pregnancy outcomes such as low birth weight, preterm deliveries, and poor neonatal outcomes such as stillbirth and congenital syphilis, even cancer caused by human papillomavirus, HIV acquisition and transmission. But control strategies rely on accurate diagnosis, not syndromic management, which I will discuss later, and also effective antimicrobial therapy. Although many of the morbidities shown in the previous slide occur predominantly among women, a large proportion of PrEP users are men, particularly men who have sex with men in a number of countries. And it's well known that some men who have sex with men also have sex with women. And this was shown in a robust population-level way in a study from Melbourne led by Deborah Williamson, which focused on gonorrhea genotyping. As you can see in the table, in the first column on the left, there are 11 large gonorrhea clusters identified. And in the fifth column to the right, most of these clusters include a mixture of monosexual men in green, heterosexual men in orange, and women in purple. And in the next column, you can see that the gonorrhea clusters also involved a mixture of HIV positive people in orange, people who are on PrEP and who are not on PrEP. Overall, about 25% of the clusters were among PrEP users, but 75% were among non-PrEP users. So this clearly highlights sexual mixing and also highlights that STI prevention among PrEP users can have far-reaching benefits. STI testing also provides an opportunity to identify gonorrhea cases efficiently and determine their antimicrobial resistance status, contributing to population-level surveillance. There are an estimated 87 million gonorrhea cases per year, and 60% of them occur in the Asia-Pacific. Many strains are highly resistant, as seen in travellers, and gonorrhea is in the top 10 pathogens, and in the US, the top 3 urgent threats among antibiotic-resistant bacteria. However, there's limited effective gonorrhea antimicrobial resistant surveillance across the region. Only a very small number of countries have comprehensive national AMR surveillance, as you can see in the dark green, and many countries, as you can see in the white, have no surveillance at all. Of those who do conduct a surveillance, samples are retained largely from symptomatic men, as you can see on the top left, sent for culture. But as we know, sampling from men only excludes all women and also key populations. Key populations are at high risk of STIs, and many of them are asymptomatic, so they're often undiagnosed and may have poor access to health services, so not reached through the surveillance. Also, culture used for surveillance relies on transport, it's complex, and it's restricted to locations near central laboratories, and therefore providing a small number of samples for the surveillance system. So overall, this lacks diversity and yield, may miss emerging gonorrhea resistance, and allows transmission to continue to be unchecked. Whereas taking the example from Thailand and the data I showed you previously, if STI testing was integrated into PrEP services, samples from anyone that tested positive, so men, women, symptomatic people, asymptomatic people, can be sent for culture. And also there's an opportunity to conduct sequencing, as you can see here. And sequencing is not affected by viability issues like culture. So this produces more samples from a wider range of people, better surveillance data, and better treatment programs. PrEP programs also provide an opportunity to offer partner notification services for those diagnosed with HIV. And for women, cervical screening could be offered involving a self-collected swab for HPV detection, which could potentially be tested using the same platform which is being used for chlamydia and gonorrhea testing and diagnosis. So what STI testing strategies are currently being used? At the moment, STI testing is still quite limited in PrEP programs in low middle income countries. And syndromic management is still being mainly used. These preliminary data are collated from PrEP programs in low middle income countries as part of a review and showed that 39% of these programs still use syndromic management only for their STI detection. 29% use a combination of syndromic management and etiological diagnosis involving an STI test, and 3% only etiological diagnosis involving STI tests only. Whereas, as you can see in high-income countries on the left, particularly in the blue, most were etiological only diagnosis. Syndromic management is based on identification of easily identified signs and symptoms related to STIs. However, as we know, most STIs are asymptomatic, so don't provide these signs and symptoms for diagnosis. Therefore, in turn, most STIs remain unrecognised and untreated. And even treatment of those with symptoms, the accuracy is quite variable. Not everyone with symptoms has an STI, and symptoms can be non-specific, which leads to unnecessary treatment and contributes to development of antimicrobial resistance. Instead, STI point-of-care tests could be used to more accurately identify STIs in people with symptoms and without symptoms, which is what was done in Thailand. Men who have sex with men and transgender people, being key populations, are recommended to have samples collected from the throat, rectum and urine, so 3 samples from one person. Thus, Thailand and many other settings have used pooling, where all 3 samples are pooled together and only 1 test done, so a 3-in-1 strategy. This means only 1 test per person rather than 3 tests per person. In addition, self-sampling is being used, where the patient collects their own samples, and this can also create efficiencies and is shown to be acceptable in all key populations, including among transgender people in Thailand. This saves time, makes the process more appealing to the client, and reduces costs. Similarly, in Vietnam, instead of using a single HIV and a single syphilis point-of-care test, the dual HIV and syphilis point-of-care test platform was being used to create efficiencies and ensuring both were tested for and to reduce costs. Over the past 10 years, there's been new developments in syphilis point-of-care tests. The previous tests detected treponemal antibodies only, which are present when a person is exposed to syphilis, whether they have recent infection or the infection has resolved. But newer tests such as the DPP Screen and Confirm detect treponemal and non-treponemal antibodies, so can assist to differentiate past from recent infections. This is important in populations with repeated syphilis infections, as otherwise people would receive unnecessary treatment each time. Such tests work best in people with high RPR titers, as shown in a number of studies. These high RPR titers are most likely in people who have infectious syphilis, which is actually the infections you want to detect and treat. So they work best in the people that you want to detect the infections and make sure they receive treatment. Also, there's a range of tests called dual HIV and syphilis tests, which detect antibodies to both HIV and syphilis simultaneously. These work well with 2 assays in a systematic review showing to have very high sensitivity for HIV, a bit lower for syphilis, but it was assay dependent, with 2 of the 3 tests still having high sensitivity for syphilis. There are also a range of molecular point-of-care tests available for chlamydia and gonorrhea, often dual tests, the first being the Expert, available in 2013, but others are becoming available or are nearly available. The more options that become available commercially, hopefully it will create demand and reduce costs. Here are some further details about some of these newly available options. Some commercially available, some still in development. Generally, they involve small devices, as you can see the picture in the middle, innovative technology. Most are dual chlamydia and gonorrhea detection, consider data transfer and mobile phone capabilities, and also provide results in 30 to 60 minutes. So in conclusion, we need to move beyond syndromic management. We need to integrate STI services into HIV services, including PrEP programs. We need access to low-cost point-of-care tests, particularly for chlamydia and gonorrhea, and need to consider creating efficiencies and reducing costs with existing platforms, such as using multiple platforms that test for HIV and syphilis together, or chlamydia and gonorrhea together, as well as some of the other strategies I mentioned, such as pooling and self-sampling. We need to use the positivity data that's generated from the STI testing to inform local policy and practice to make the case for the integration of STI testing into PrEP programs. And we need to capitalise on opportunities to provide other complementary services, including using the positive results from those tested for gonorrhea for AMR surveillance, and also for anyone tested positive for STIs, offering partner notification services. So thank you very much to everyone for listening. I'd also like to thank a number of people who are listed on this slide, who provided slides for this presentation. And you can see the names here: Heather Marie Schmidt, Nitya Panapak, Ben Bavington, Louise Causa, Hamish McManus, Sky McGregor, Tanya Applegate, Yang Zhang, and also Michael Traeger from the Burner Institute. And I'd just like to Thank everyone for listening today, and I really hope you enjoyed this really important conference. I know that I have. Thank you.